Thank you, and thank you for having me again. I have to say that when I was assigned this topic, I realized that half an hour is definitely not enough time to talk about this very vast. C'est un sujet qui est très très vaste. Donc, what I thought is, if I have to talk about all pulmonary disorders and the way evaluated by CT, I'm going to spend 4 or 5 hours. So please bear with me if I'm going to be speed talking. I realize that we have only 25 minutes and I have 265 slides. And that's how we need to do in imaging. It's all about visual, so please bear with me. But what I want to do today is really looking at pattern recognition and how we can basically with a broad brush trying to look at different entities as far as interstitial lung disease, pulmonary disease, nodular disease, trying to identify those lesions, see how we can come up with differential diagnosis rather than going to a very single pulmonary disorder. So, and typically to evaluate the lung parenchyma, we're going to use high-resolution CT. And you need to realize that all CTs now basically give you a high-resolution images. Everything from a 4-slicer all the way to 228 slices, just how you choose to basically display your images. But the goal is to optimize the visualization of the lung parenchyma to the finest possible detail. And obviously, with cross-sectional imaging, then you can further analyze the content of the lung parenchyma. And that allows us to resolve anatomic structures and pathological changes at the sub-millimeter level. And I think that's really helpful, especially if you're looking for early or minimal disease. And this is an example from going from the right to the left on how just on the same technique, on the same image, how you can change the technique and then have a better resolution of the lung parenchyma. So you go from an 8-millimeter slice thickness to a 5-millimeter slice thickness to 1-millimeter slice thickness, and now you can see that the detail of the lung parenchyma is to much better. You can see it to a much better extent. So actually here you do see the lung parenchyma and the vessels and the bronchi, but you really start to suspect that there is something going on here at the periphery of the lung. And it's not until you do a high-resolution image that now you can see there is actually early and minimal interstitial lung disease. And again, just changing your thickness can allow you to have a much better resolution of your parenchymal pathology. And again, this is again just showing that even in this slide, this is a relatively high resolution, 5-millimeter slice thickness. We think that there may be alveolar disease combined with interstitial lung disease. And it's not until you look at the high resolution slides that you can see actually this is a framework of very advanced interstitial lung disease, even though it's localized and geographic. And just as far as technique, remember that we have to inflate the lungs to a maximum to be able to evaluate the lung parenchyma and not to having crowding of the lung markings and hypoinflation giving you pseudo disease. Remember that from time to time, if you want to evaluate parenchyma to a small region, targeting is very important. And targeting, this is not just magnification. You're actually concentrating all your pixels and all your voxels into one area. And this is important if you evaluate localized disease or if you evaluate pulmonary nodular disease, especially solitary pulmonary nodules. So targeting can be of some help. And today's scanners, you don't have to reconstruct. When you reconstruct and you obtain the data, you can reconstruct with the same high resolution in all different planes in both axial, coronal, and sagittal, and have the same degree of detail and the resolution on all those planes. This is a patient with Wegener's granulomatosis showing this cavitary lesion, but also it does tell you its relationship with the different other portions of the lung, its relationship to the other lobes, to the fissures, and so on. And one thing also, obviously, with high-resolution CT, we can find early and minimal details. So this is a patient with early pulmonary embolic disease with a small subsegmental PE. And again, this will allow you, because of the resolution, you can see some minimal disease. And you can display it in different plans. So if you look at, in general, what do we do a CAT scan? Remember that also a chest X-ray is the very first line of screening or the very first line of evaluating in general pulmonary diseases. But if you suspect, for instance, pulmonary embolic disease, you know that chest X-ray is not going to be very sensitive. So for instance, for the evaluation of pulmonary embolic disease, CT is definitely the first one that's being indicated. Nodular disease, most of the time you're going to see them on the chest X-ray, and then you further evaluate that on the CAT scan. And then in general, cystic and cavitary disease is better evaluated with CAT scan. Airway and Esper's disease, especially in early disease, you're going to see that CAT scan does have a value. And And then if I have time, I may talk a little bit about interstitial lung disease, especially the idiopathic interstitial pneumonias. This is a whole topic by itself that we may spend a couple of hours, but I'm just going to very briefly brush on that. If some people have attended some of my talks before, I do like to emphasize about the relying on the basic anatomy to be able to understand the pathology, especially pattern recognition. And this is a slide that I obtained over 30 years ago, but there was at a time when CAT scan just came along, and then it allowed us to evaluate the lung parenchyma, try to understand what's the anatomic structures and the basis of pathology. And if you look at what we display in the lung parenchyma and you display it on the CAT scan, you're going to see this uniform appearance of the lung parenchyma filled with air, and then you have bronchi and vessels, both pulmonary arteries and pulmonary veins. And they do are better seen in the central portion of the lungs, but as they taper toward the periphery, then they become smaller and they fade away into the periphery. And then you can recognize the fissures and so on. But I think what's important is to be able to recognize the core structure of the lung parenchyma, because everything that happened within the lung parenchyma is going to be a reflection to what happened at the core structure. And when I talk about core structure, I'm talking about the secondary pulmonary lobule. So again, this is the specimen showing how there is a bland appearance of the lung parenchyma, just the air and the supporting connective tissue and vessels and bronchi. However, it's not until you look at very closely at the periphery then you start to recognize these single units which represent the outline of secondary pulmonary lobule outlined by interlobular septa. So the interlobular septa, as basically, if you look at the specimen, this is a patient with a little bit of anthracosis, and you can see it's outlining the interlobular septa. But you have this framework of polyhedral structures that represent the secondary pulmonary lobule. And if I render that through a diagram, this is 4 secondary pulmonary lobule. I magnify them, and this is basically anatomically how they're depicted. So you have these polyhedral structures anywhere between 1.5 to 2.5 centimeters in diameter. And outside of the secondary pulmonary lobule, you have this supporting connective tissue and the interlobular septa. Within them run the veins and the lymphatics. And then in the center of the secondary pulmonary lobule, you have the core structures, which is the core arteriole and the core bronchiole. And I'm just going to go very briefly, and I'm sorry if I'm going through something that is very basic, but it allows you to understand basically what happens in the lung parenchyma. And once it happens, how can you recognize it, and how can you separate it from different processes, from interstitial and alveolar in particular. I'm not going to go through this, and I'll be glad to provide this as a PDF file for people that are interested in knowing some of the diagrams and the basic anatomy. But just remember, again, the second pulmonary lobule outlined by the interlobular septa. You have the pulmonary veins and the lymphatics, actually, that also run within the supporting connective tissue and the bronchiole and the arteriole. Now, the acinos can be also recognized if there is disease, acinar disease. So you're going to see that as a polydefined opacity that is anywhere between 5 and 10 millimeter in size. But the problem is that beyond the acinus, then as far as looking at the alveoli, that's something that we cannot resolve anatomically, because now we're talking at the level of the micron. So the terminal bronchiole may be seen, but then after that, beyond that, that's not something that we can resolve even with the most powerful CAT scan that is available to us. So all the different respiratory bronchioles, especially in the small branching orders, all the way to the alveolar duct and to the alveolar sacs, those are not going to be seen morphologically on the CAT scan, again, because they're just too small for us to identify. But this is a normal patient, a live patient. And again, if I take you back to how do you recognize the secondary pulmonary lobule, so they're better seen in the periphery. Just remember that we think sometimes the lung as just like a kidney. When there is a cortical portion, so the peripheral portion for which the secondary pulmonary lobules are very well aligned and outlined by interlobular septa. As you go toward the center of the lung, then they're not very well seen because they're not arranged as well and stacked as well, but also there's a lot of communication and disruption of the interlobular septa. But again, just to go back to this secondary pulmonary lobule, you can recognize it there. You recognize it as this polyhedral structure. Here's another one next to it. And then you see the interlobular septa outlining those secondary pulmonary lobule. And then you look at the arterioles, the core structure within the center of the lobule. And this is very important as we're going to look at pathology. And then you see the venous branches. And then if you want to follow them, then you can go all the way. The same thing with the arterioles. You can follow them all the way to the level of the hyla, going into the pulmonary artery branches. And then the same thing with the pulmonary veins. you can follow them if you want, if this is important to you, and to try to recognize them separate from the pulmonary arteries. So if you look at pattern recognition, the things that we need to recognize are basically 4 different patterns that are going to be seen on the CAT scan. You may see decreased lung capacities, so basically you're talking about cystic changes and cystic disease. You have increased lung capacities, and that typically you are talking about airspace disease and alveolar disease. And then you have localized nodular opacities. Those usually do not necessarily respect the boundary of a secondary pulmonary lobule. And the reticular opacities, obviously, those are the signs of interstitial lung disease, and those are going to be recognized as involvement of the secondary pulmonary lobules at different levels. So, you can look also at the different opacities and how they, the Hounsfield units, if you want to put a cursor on those different patterns. But this is, again, just looking at the secondary pulmonary. So let's talk a little bit about cystic disease. And I'm not talking about localized cystic disease. I'm going to talk very briefly about general cystic disease. And the best example is going to be a patient with pulmonary emphysema, central lobular pulmonary emphysema. And I don't know how prevalent it is here in Lebanon, but obviously if there is a high prevalence of cigarette smoking, that's something that you're going to be able to see. So one thing that you need to recognize about the central lobular pulmonary emphysema, besides the fact that it does follow the anatomy of the secondary pulmonary lobule, most of the time those cystic changes do not have a definable wall, in contrast to other diffuse cystic disease such as lymphangioma or histiocytosis and so on. So here we're talking about areas of punch-out, areas of decreased opacity because there is no lung parenchyma, and it does follow a particular pattern with the secondary pulmonary lobule. And here's a good example. So we're talking about those areas for which there is a decreased attenuation of the lung parenchyma. And you see here's a nice example of a secondary pulmonary lobule for which you did preserve the anatomy of the vein and the arterioles, but again, you have decreased opacity in comparison to the areas where there is almost normal lungs. And I think this is very important to recognize, especially in early central lobular pulmonary emphysema. In patients with advanced pulmonary emphysema, you really cannot, as a clinician, you cannot do anything. This is advanced, it's already settled in, it's not reversible. But in early central lobular pulmonary emphysema, this is a patient for which you can tell them there is a damage there, and then you can probably use it as a deterrent for them to stop smoking. And this is a case, for instance, where the patient passed away, and the chest actually looked normal. But if you look at the specimen, look how much pulmonary emphysema. So if you look at grading this, if you want to grade this is a 50% involvement, obviously subpleural blast. But you cannot wait for just the overexpansion of the lung parenchyma to call it emphysema. You have to be able to detect the earlier changes of central pulmonary emphysema. And then obviously these areas of central pulmonary emphysema that involving the secondary pulmonary lobule can coalesce together and form large areas of Buddhist disease. And a specimen again showing a large advanced pulmonary disease. And this is again the areas or the time when you can make an influence on the patient when you detect this early pulmonary emphysema. And this is what we see on a live patient, those very small areas. We realize also that those black areas are not really defined by a well-defined wall within those areas of decreased attenuation. Just to be complete, a patient with panlobular pulmonary emphysema, when there is more at the level of the sinus and there is diffuse involvement, it still somewhat preserves the anatomy of the secondary pulmonary lobule, but it's much more diffuse. And a good example of this is a patient with alpha-1 antitrypsin deficiency, for which you can see because of its distribution, it's more involving the lung bases in comparison to the central lobular pulmonary emphysema, where you have more involvement of the apices of the lungs. And then also as part of central pulmonary emphysema, there is one particular emphysema that has this peripheral typical distribution. We call it Paraceptor pulmonary emphysema. And you see those large areas of coalescence of blebs and Buddhist disease where you have preservation of the central and medullary portion of the lung. But again, this distribution will allow you to recognize this central lobular pulmonary emphysema. Also, what they do here is when you have, every time you have peripheral cystic disease, there's always a risk of having a pneumothorax as one of the things that can rupture into the pleural space. And you can see this patient has a pneumothorax because of the peripheral appearance of the blebs. This is just to contrast you in a patient that has diffuse cystic disease in comparison to the patient with pulmonary emphysema I showed you, either central pulmonary emphysema or panemphysema. Look at the fact that the cysts are uniform, but they have a well-definable wall. You see there is this white line here that's surrounding all this area. So this is true cystic disease for which it does involve the secondary pulmonary lobule, but again, it does not have any kind of predilection for the secondary pulmonary lobule. More importantly, it does have a wall surrounding the areas of paucity. This is a patient. Can anybody tell me what this disease is? So the cysts have this bizarre appearance. So this is Langerhans cell histiocytosis. Again, diffuse disease, you may have some nodular disease, but again, look how it contrasts with a patient with LAM, or especially with a patient with pulmonary emphysema. Here's another patient with Langerhans. How about this one? So now we see a lot of cystic disease here. Now this one has a wall. The rest of the lung parenchyma looks fine, but look at the distribution of those cystic changes. They're more to the center of the lung. Well, I showed you a patient with Paraceptor pulmonary emphysema. Now this one is the opposite. It's more medial. Anybody? Bronchiectasis, exactly. And we tell that bronchiectasis by the fact that it does follow the anatomy and the distribution of the bronchiectasis. But when the bronchiectasis is very advanced and you have cystic bronchiectasis, then it can mimic cystic disease. But those are all bronchi. Now we're not talking about within the parenchyma as a secondary pulmonary lobule. We're talking about the bronchi being very dilated. Now, the other clue that you see here is this. This is tracheomegaly. So this is a typical patient with Mounier-Kuhn when you have tracheobronchomegaly and cystic bronchiectasis. And one thing that we use CAT scan for is for the diagnosis of a bronchiectasis. And we look at bronchiectasis basically looking at the anatomy, looking at the fact that they can follow the normal bronchi, and that also they're obviously dilated. And we look at the signet ring sign, for which we look at the bronchi and the accompanying artery. We don't do this anymore, but when I started my training, we were still doing bronchography. So we stopped doing that 4 years ago. All we need is a couple of slices. We look at the bronchus, we look at the accompanying artery, and this is the signet ring sign, for which when we tell that the bronchus is bigger than the accompanying artery. Normally, it's the opposite. It's either the same size or smaller than the accompanying artery. So this is an easy way to make the diagnosis of bronchiectasis, but we can consider it in advanced changes as a patient with cystic disease, but it's really airway disease if you want to go by definition. Here's another patient with tracheobronchomegaly with cystic bronchiectasis, the same thing here and the same thing here. So this is an easy diagnosis to make as you can follow it with the anatomy and the branching of the bronchi. Here's another patient, again, with cystic bronchiectasis. Nodular disease. So this is, again, by itself, it's a long topic. I can spend maybe 4 or 5 hours talking about pulmonary nodule, but just very briefly look about how we can use high resolution, or just CT in general, but high resolution CT in trying to determine the nature of the pulmonary nodule. And by definition, I'm talking about solitary pulmonary nodule. So by definition, a solitary pulmonary nodule is a sharply defined opacity anywhere between 0.2 millimeters, that's the level of our threshold of resolution, up to 3 centimeters. Beyond 3 centimeters, now we're talking about masses, and that's something that has a totally differential diagnosis. We're talking about tumor then most of the time. We need to realize that there are numerous benign and malignant causes, and our challenge as a radiologist is to need to detect cancerous nodules at a manageable stage. And we have to also, at the same time, as I talked to you this morning, if you were present, talking about the early detection of lung cancer, we have to be able to refrain to intervene on benign lesions. We don't want also all those positive to create trouble for the patient. 2008, do you see the nodule? It's here. This is too big to be a vessel. You know how the vessels are branching as they go to the periphery? 2007. Well, actually, it looks bigger. So if it was bigger a year before, then what do you do usually? You forget about it. This is, but the problem with that, being such a small nodule, you have to be careful also about making sure that you did cut exactly to the same level. If I go 2005 now, it was smaller in 2005, got bigger in 2007, then got smaller again in 2008. What do? You have to go to the very first CT or X-ray to make sure that you do see a true evolution. You cannot compare it just to the most recent one, because this is what happened and this is what I did. And the patient came back in 2011, and this is an obvious tumor that has metastasized. So CAT scan can help you into trying to detect a nodule, but also further try to characterize it. We characterize it by its appearance, by its shape, but also sometimes when it's indeterminate, we characterize it by its size, and especially its growth and its evolution over time. So that's our best help, because again, when they're very small, it's hard to characterize them. And we looked at different things now. So CAT scan obviously will allow us to look at the content of the nodule because of the cross-sectional capability. And we look at how we characterize the pulmonary nodule. We can look at the presence of calcium and the different patterns of calcium, and usually those are all meaning benign disease, usually granulomatous disease. You have the popcorn calcification, that means usually it's a hamartoma, but just remember hamartoma is better diagnosed by the presence of fat. But you just remember that also there are calcifications that are not necessarily meaning benign disease, and we may be able to see some of the examples. Then you have to look at the border of the lesions, and obviously a spiculated lesion or lobulated lesion or combination of both usually means malignant disease. And the problem is that the majority of the nodules are actually with this. No calcium, no typical appearance of the contour. Then we have to deal with the pulmonary nodule that is indeterminate. And then we have to be able to know how to manage those nodules, and we can look at the Fleischner Society guidelines. Again, I want to go back to the fact that targeting can help you, and then if you target the lesion, you have better information. Now you can see that this nodule now with the targeting, you can see it has spiculate margin, that means it's most likely cancer. It's cavitary, that means it's squamous cell carcinoma, and it hasn't crossed the fissure. All important information for planning on how to tackle this lesion. This turned out to be a stage 1 squamous cell carcinoma. Sometimes, again, if you don't have the right technique, this is a patient that is a smoker presenting with a newly appearing nodule. Told us that the patient probably need to surgery. The patient was very anxious to go to surgery. We told them, let's repeat the CAT scan, make sure that we have a good view of the inside of the nodule. And then we do a thin slice, and then we can see that the patient does have a calcification within the center of the nodule that allows us to tell that this is a benign nodule and not to put the patient through surgery. So simple techniques to just try to better evaluate the pulmonary nodule once you have detected. Patient that went surgery by mistake, this is a patient with a nodule, but there is a vein coming into the lesion. This is a pulmonary AVM, and that should not have gone to surgery is if you have been able to detect that this nodule did have some vessels connected to it. The best way to evaluate the pulmonary AVM is to be able to inject contrast and to see that the contrast is enhancing the center of the nodule. You do see the accompanying artery and feeding vessels coming into near the lesion. But again, as a pulmonary nodule, they have different patterns to recognize. You can look at the appearance of the nodule, you can look at the content, and then try to determine whether this is a benign or malignant. And of course, CATs can allow you to plan for transbronchial biopsy. This is a typical bronchus sign on a patient with the breast cancer. How much time do we have? 5 minutes. Okay. Well, let me skip to the multiple pulmonary nodules. There's a whole pattern recognition of pulmonary nodules. This is a patient that have typical appearance of the pulmonary nodule with a halo sign. Those are basically seen in a patient with invasive aspergillosis, but they can be seen in hemorrhagic cancers. I'm going to go very quickly, but I just want to go into the interstitial lung disease. I think that's important for us to recognize. Patient with sarcoidosis with the distribution of pulmonary nodules. I don't think I want to bother you with multiple pulmonary nodules. Airspace disease and central lobular pulmonary nodule, just remember they have a typical distribution. You have this basically fruits at the end of the branches, and this is typical of a patient with early nodular disease due to airspace disease, and the typical example is early infection, but then you can be seen in patient with bronchoalveolar carcinoma, as we can see. But again, early changes have the typical tree-in-bud appearance in a patient with early alveolar disease that can evolve to a airspace disease. So airspace disease, it's easily recognized when it's diffusely consolidated. You see the air bronchogram, and you see, but when it's early, then you can look at early non-specific nodular disease. But those usually don't have a very well-defined border, and they're very hazy. As they evaluate into more larger lesions, then you can recognize them as the size of the acinus, the 5 to 8 millimeters, and those will conglomerate together to form segmental lobar disease. So this is just to contrast it with interstitial lung disease. So this is airspace disease, and you know that the multiple causes of airspace disease, what do you have in the airspace? You can have pus, you can have blood, you can have fluid, water, so patient with pulmonary edema, and you can have cells and proteinosis. So if you recognize it, then you can at least go to a differential diagnosis. Very often what you have is both airspace and interstitial lung disease. So airspace disease, these areas of fluffy white appearance, and then interstitial lung disease. You remember the secondary pulmonary lobule? Here's one secondary pulmonary lobule with its outline with the interlobular septa. Here's another one with the central arteriole. This is an example of pulmonary edema that has gone from interstitial to alveolar disease. We don't do a CAT scan pulmonary edema, but again, for pattern recognition's sake, this is how we recognize it, and that's how we contrast airspace disease from interstitial lung disease. And then you have the ones where you have these ground-glass appearances combined with both interstitial and alveolar disease, the crazy paving pattern process. I'm not going to bother you with that. This is a relatively rare disease, but again, as pattern recognition, this is alveolar proteinosis. And if you've seen it once, you'll be able to recognize it. And again, you have a combination of both a framework of interstitial lines and then opacities due to ground-glass alveolar disease. So interstitial lung disease will be recognized as this framework of thickened reticular lines on the chest X-rays and on the CAT scan. On the CAT scan, this is what you see. You have different degrees. You have thickened and irregular interfaces. It's these early changes in interstitial lung disease in the periphery of the lung and along the bronchovascular bundles. But then also you have this framework of thickened interlobular septa that outline the secondary pulmonary lobule. And then within the secondary pulmonary lobule, you have different degree of involvement. You have intralobular interstitial thickening. So very briefly, to just go to look at this, patient with early pulmonary fibrosis, early interstitial lung disease. The cause can be fibrosis, can be inflammation. Those are the most common causes of interstitial lung disease, but by far it's going to be fibrosis. And this is the early patient, where for early patients with interstitial lung disease, this is a patient that has normal chest X-ray, but abnormal pulmonary function test. And a patient with polymyositis, we try to see the reason of the abnormal pulmonary function test. And it's not until you do a CAT scan you can see that there is early interstitial lung disease. The same thing here as you see in the periphery of the lungs. But you want to make sure that this is a fixed phenomenon. This is not just some dependent atelectasis. Other things that you see in the early change of interstitial lung disease is those subpleural lines. And the typical example is patient with prior asbestos exposure. We've seen on other entities, but the typical reticular lines due to early interstitial lung disease due to fibrosis and asbestosis. I'm going to go through this just example on how they contrast it. But this is...
2 minutes, Dr. Meziane.
Okay.
2 minutes, please.
I'm just going to stop here, but basically, this is a good example of interstitial lung disease. Again, these reticular lines outlining secondary pulmonary lobule. I was going to go to the different causes of interstitial lung disease, trying to contrast them between fibrosis versus tumor and so on. But as long as you'll be able to recognize it, I think this is very important. And this is how we contrast it also with the airspace disease. So again, this is a very, very long topic, and I was asked to talk about this that on a half an hour. It doesn't give it a credit, but I'll be glad to extend it if anybody wants to have a private lesson, and we can go and talk to this. Okay.
Thank you, Dr. Meziane, for your nice presentation. If you have 1 or 2 questions, please.